Hi, everyone. Welcome back. Today, we're joined by Dr. Stenehjem to give our weekly COVID-19 update to the community. I'm going to start, as always, with case counts and trends and what's been happening since the last time we spoke. Our total case counts for the state of Utah are at 170,584. The daily case counts for today just came out at 4,588. We have a total of 773 deaths, and today's reported deaths was 18. Our total hospitalizations throughout this pandemic has been 7,350, with 533 people reported in our hospitals today. Our referral ICU capacity is 93.8%, and I want to start with that piece of information. There's two different pieces of data on the state's website. There's the overall ICU capacity and the referral ICU capacity. Dr. Stenehjem, will you break down what those two numbers mean for people and really which one they should be looking at?
Yeah, I mean, first of all, they're both high. So it's not like there's a big difference between them. They're both above that 85% threshold that we've set for being considered full. A referral ICU is an ICU, for example, here at Intermountain Medical Center, the University of Utah. These are larger referral centers that we have in Utah. McKay Hospital, Utah Valley Hospital, St. George Hospital, within the Intermountain system are all referral centers. And so those are referral ICUs. These are where the sickest of the sick patients go. This is where the most specialists are. ICU trained physicians are located there. Non-referral settings are in hospitals that are smaller, community-based centers. So like within Intermountain, that would be like an Altaview, a Riverton, Delta, Fillmore, some of our smaller facilities that may not have on-site trained ICU doctors. But would still have a number of ICU beds. And so it just speaks to the acuity of care that those hospitals typically manage.
I have another quick question about that too. I keep hearing that it's not 100% full, therefore we have this capacity to take in patients. What is the typical ICU capacity like in a non-COVID-19 year? What's the normal percentage for a hospital load?
Yeah, so I mean, you really want your ICU capacity to be less than 85%. If you had an ICU that was 100% full, that means you can't bring anybody in. So if there was a trauma or a heart attack or a stroke that needed ICU care, that person would have to wait in the emergency department until a bed becomes available in the ICU. And so within an ICU, you always want to have a number of beds open so you can accommodate either sick people on the floor needing to be transferred into the ICU or people coming from the ED and being admitted. It takes time to turn over an ICU room. They have to be thoroughly cleaned and prepared for the next patient. And so you never want to run above 85% because if you do, you're running into problems about patient flow in terms of getting a patient into the ICU, getting other people out. And so, anything above 85% is really unfortunate and really in a scary position because you limit your ability to get patients into the ICU. We typically always run less than 85% within our hospitals to make sure that we can accommodate all our patients that are seeking care.
And it seems like today we are reaching a new record with our case counts. What does this feel like to you? Are we going in the right direction? And also, is this positive rate in alignment with what we've had in the past, or is it going up? What are those trends like?
I mean, this is just crushing. I mean, to be perfectly frank with you, Amanda. Yeah, today was another record-breaking day, 4,500 cases. Prior to that, our record was 4,000 cases. We are continuing this trend that is clearly unsustainable from a healthcare standpoint. And not only have we had the highest amount of cases today, being reported today, is that we have a national holiday next week, which is going to just amplify continued transmission. So this spike couldn't have come at a worse time in terms of potential of what's to come. I also think, we breeze over 18 deaths. That's 18 individuals that won't be at Thanksgiving, that won't be at Christmas. In the US, we've had 250,000 deaths of COVID-19. and we haven't even gotten into the winter. And so that's hard to, we think about these numbers, they're really big numbers, but those are individuals, those are people, those are parents, those are grandparents, those are children. And 250,000 people have lost from this. I mean, perspective wise, a bad flu year would account for 40,000 deaths across the US, which is tragic in its own right. But this is 250,000 and we haven't even gone through the winter. And so, we are on track to having, similar, profiles and deaths from some people say 1918 flu. I mean, this is just absolutely tragic. So, I think we should just recognize that these are all individuals that aren't going to be at Thanksgiving. These aren't going to be at Christmas. And we're going to see more and more of this, unfortunately. And so here in Utah, our numbers are terrible. They continue to worsen. And as we predicted, weeks ago, as we saw this spike coming, we said, yeah, deaths aren't here yet, but they're going to come. And now you see that this was the deadliest week in Utah from COVID-19. I guarantee you next week is going to be deadlier than this week. And if we continue on this trend, we're going to see the week after that being deadlier than the week before. So it's a really bad trajectory that we're on. If you look at our hospitalization numbers, 93% capacity in the ICU. We don't have a whole lot of we don't have a whole lot of wiggle room left, right? And that's with us opening up new ICU beds that typically haven't been opened in the past. And so we're heading down a pretty dangerous path right now.
You bring up the number of deaths that happened, and I saw this earlier today. Somebody posted an analogy of an airplane crashing I don't exactly know the exact quote, but there was an analogy of an airplane crashes every so often. That's how many people we're losing. And the fact that we'd probably take that very seriously if there kept being airplane crashes that were happening. 9/11, we did not lose this many people. And our nation kind of came together and resignated under what was happening. And for me, it's really hard to see that people don't see that 250,000 people as a person, like you just mentioned. Our CEO, Mark Harrison, in a press conference on Monday, talked about that, how at that point, it was 730 people were not going to be in Utah enjoying Thanksgiving. And it's really important as next Thursday comes up that you remember that people, like you just said, don't have family members with them at Thanksgiving. So even though it may seem small, it's not small.
No.
You brought up the flu aspect too, and I want to quickly touch on that. So you mentioned that in the past, the flu has been nowhere near the death rate that we're having currently. I know the flu season started. Do we have any sort of indication of how that's going to perform this year, or are we counting flu less this year than we have in the past?
No, so keep in mind that influenza is detected at a very different test than the SARS-CoV-2 test. So these are two completely different tests. They're testing two different viruses. We've had so far 2 cases of influenza in the state of Utah. Both have been influenza B. We are actively looking for influenza. It's really important for us, especially this year, to know when we start to see an upswing of influenza cases, because we really don't want to miss influenza and think it's COVID, because influenza has treatments. They have treatments that work, especially if they're started early. And so this is something we're looking for. We're actively testing for influenza using specific influenza A and B tests. And so far we've seen 2 cases, which is not atypical for this type of year in November. It's really going to be how quickly do we see a rise? Is this something where we see low levels of influenza that have occurred elsewhere? Or do we see a massive uptick in influenza cases coming November to December? So it's something we're really going to watch very, very carefully in the coming weeks, actually throughout the whole season, to really have a better handle of what's going on with influenza.
I want to talk about the 2-week pause that has been in effect. It ends on Monday. It's been almost 2 weeks since it started, where the governor asked us to limit social gatherings to being at home. We have a statewide mask mandate, which is continuing past Monday. Have the mask mandates or the social gathering mandates made a difference in our case count and the trajectory that we're currently on?
It's going to be really hard to tell us to say, yes, it worked or no, it didn't. We don't know what cases would have been if that mandate didn't go into effect a week ago last Monday, which limited social gatherings to those just in your house, stopped extracurricular activities for schools, and instituted the statewide mask mandate. We don't know if cases today would have been 6,000 or 7,000. We know today, though, that they're the highest they've ever been, 4,500. And we should have started to see some effect by now. So we're now probably 12 days into that mandate. So we're getting to the far end of that viral incubation period. And so we should be seeing some mitigating effects. So can I say they worked or didn't? I can't say that. But what I can say is that they didn't work enough. What the whole point was to take that 2-week pause and get our cases to drop. And so if we could get our cases to drop, we knew that we would be decreasing the amount of transmission in the communities, which would then lead to decreased transmission at Thanksgiving. We haven't seen that. And I don't expect, given the way our curves look, that we're going to see any significant change in terms of our numbers on Saturday or Sunday or Monday. And so do they work? I don't know, but they didn't work enough for us to really reap the benefits of a true 2-week pause.
I also think that that's interesting that you brought that up, that we don't really know if it worked or not. And I know from just my personal social media and looking at things, a lot of people didn't really take that to heart. It seemed like people were saying, hey, you can't come into my house, you can't tell me how many people to gather. But the long-term effects of it is that if we can get our counts down, we can spend Thanksgiving and Christmas with our families, which is the ultimate goal. No one wants to be alone during the holidays. So whatever we can do before that, we need to do. So Thanksgiving is Thursday. What are your recommendations for people? What do you suggest that people do?
I mean, first, I do want to say that there are lots of people in Utah that are taking this incredibly seriously, and to them specifically, thank you. Thank you for doing that. You're the reason that our cases aren't 6,000, 7,000, 8,000 today. So, I think it's really important for us. People are doing a lot of really good things.
Eddie, it seems like we might have lost you.
Fortunate that. Are you back, Amanda?
I think so. I think we are both back. Sorry about
Okay.
that. Yes, you seem to be back. I seem to be back. We're good.
Yeah. No, so I guess if I got cut out, I mean, our recommendation is fully in line with the CDC and the fact that we recommend that you do not gather with people outside of your home for Thanksgiving. It's unfortunate, right? Thanksgiving is the time we love to get together with friends and family and watch football and give thanks and do all those things. I know that's one of my favorite holidays, frying a turkey with family. I mean, that's just what we like to do. But this year, it's just not safe to gather with people outside of your family. We know that if you bring people in to your home, you're now in a home indoor environment, you're eating, you're drinking, that is a perfect place to transmit the infection. And we are very nervous that what we'll see after Thanksgiving is a continued rise in cases because of ongoing transmission. So pretty clear from our standpoint, Intermountain Healthcare is that you don't gather outside of your homes.
And I know that a couple of weeks ago, we were talking about things you could potentially do. At this point, it's a little too late for that. If you haven't been quarantining or taking the necessary precautions, it's hard to flip that switch because Thanksgiving is in less than a week. So I think that's important to consider too. Have you hung out with people in the last couple of days? Have you done other activities that would put those people at risk to come to your house?
Yeah, and with numbers this high, the chance that somebody coming into your home is asymptomatically or in this pre-symptomatic phase is high. It is very, very high that if you are bringing people in from the outside, especially those that haven't been, heeding, preventative measures, the chance of somebody being in your home that has active COVID or active SARS-CoV-2 in their nose is really, really high.
I want to switch topics really quick to vaccines. looking to the future, hopefully a brighter future. There's been a lot in the news about Pfizer and the Moderna vaccines. Pfizer just updated its data and said that it's now 95% efficiency rate, whereas the Moderna one is 94%. Can you talk to us a little bit about how those clinical trials work in terms of getting to that percentage? And also, is there a difference between the two vaccines?
Right. So this is exceptional news. We've talked on a couple previous Facebook Lives about what we anticipated the efficacy rate of this vaccine to be. And, most people were being cautiously optimistic and hoping for an efficacy rate around 60%. Okay. Pfizer now releases that their efficacy rate is 95%, which is consistent with the Moderna vaccine. So this is just incredible news for us in the infectious disease community and public health community. So let's just think about these trials. So what happened is within Pfizer, they had 43,000 people in the trial. Half of them received vaccine, half of them received placebo. Okay, meaning they got salt water, they got absolutely nothing. The individual participants have no idea if they got vaccine or not. Okay, so they're exposed to the same type of environment. There's no difference in that. The first look at the data with Pfizer was a look by the Data Safety Monitoring Board, the DSMB. This is that external group that reviews whether or not that the initial study results are looking promising and that they're safe. Okay, that's when we first got that report out from Pfizer that it was 90% effective. Okay, that was a look when they had about 94 different events. And we're going to talk about what that means now. Now, what they did is that they had a stopping point to evaluate for FDA approval under emergency use authorization after they hit 150 events. Okay. And Pfizer actually hit 170, I believe. And so at that point, they stop and they take a look at that data. And so what do I mean by 170 events? So within the Pfizer study, what they're looking for is symptomatic infection due to COVID-19. And so did an individual present because they had symptoms of COVID-19? It could be mild symptoms, could be severe symptoms, doesn't matter. There's any symptoms of COVID-19. And so they waited until they had 170 patients of their 43,000 that got randomized. They waited for 170 events to occur. So 170 infections with COVID-19. Once that occurred, then they said, okay, let's take a look at, of those 170 infections, how many of them occurred in the vaccinated population and how many occurred in the unvaccinated or the placebo population. And that's how they calculate their efficacy rate. So in this instance, they had 170 cases occur amongst the 43,000 people that were in the trial. Of those 170 cases, 162 of them were in the unvaccinated group and only 8 were in the vaccinated group. Okay. And so that distribution, 162 divided by 170 is 95. Okay. That's how you get the efficacy rate. And so the vast majority of people that got infected in this Pfizer study were in the unvaccinated group. Okay. And so that really proves to us that, 28 days after that initial dose, that these people in the vaccinating group are protected from SARS-CoV-2. It just gives you a look at that at 28 days after, that's what we're seeing. So this is a really good sign. Moderna published similar results with not as many events because that was their first look at the data under the DSMB. Once they hit at least 150 events, that's when they'll look at their data, probably put out another press release, and then be able to apply for an FDA EUA, just like Pfizer's doing. Pfizer is likely submitting an application either today or by Monday to the FDA for an emergency use authorization. Once you get that EUA from the FDA, that's when we can start vaccinating people.
It seems like a battle of the science of who can get the higher percentage, but it's great to hear that, especially because we know the flu vaccine is definitely a lot lower than that. So that's really encouraging.
I wouldn't compare, it's too early to compare efficacy. So 95 versus 94, statistically, that's the same thing.
Right.
So as of right now, what we're seeing, and this is really good to see, is that So the Moderna vaccine and the Pfizer vaccine are both the same type of vaccine. These are called messenger RNA vaccines. We're essentially delivering a little bit of genetic code into an individual. It's being taken up by the cells, and the cells are then making the spike protein, which is what stimulates the immune response to protect you from COVID. And the fact that both of these vaccines are giving very similar results really reassures us scientifically that this is going to be a vaccine that's going to be effective.
And someone just asked about long-term effects of the vaccine, which we obviously can't really distinguish those at this current moment in time. Although I have read that this vaccine was developed from other vaccines, or kind of that's how they were able to make it so quickly. What is the real scientific explanation behind that? And what could there be long-term effects?
So when you look at vaccine trials and you look at when do serious adverse events occur from a vaccine, the majority of those serious adverse events occurs within 2 months of getting the injection. Okay, and so the reason that the FDA said, listen, we're not going to look at any EUA applications unless you've got at least 2 months of follow-up data for your vaccinated population, is that we know that is the period that the vast majority of adverse drug reactions or adverse reactions to the vaccine will occur. And so in both the Moderna and in the Pfizer, more data in the Pfizer shows that there was really no signal of serious adverse events in the vaccinated population compared to the unvaccinated population. So, but I think the listeners ask about longer term effects. So those are very uncommon and really hard to pin to a vaccine because so much happens in that time between the vaccine and whenever this event would occur. So those are things that we have to do what's called post-marketing surveillance for, is to look at the populations that received these vaccines and see if anything consistent happens to them over time. And so that's really what kind of a phase 4 trial. We think about phase 4 in terms of once a drug or a vaccine is approved, that we see if we find any very rare adverse events associated with it. So as it stands right now, these vaccines look good, and they look like they have a very low rate of any kind of safety events within the 2 months of follow-up that we've seen so far.
That's interesting about the 2-month mark. I didn't know that. So that's good to clear it up. One more question for you about vaccines. If you're given the chance to get the vaccine, you qualify for this first phase. What are some things you should consider before you actually end up taking it, like your risk levels or anything like that? Is there anything you should consider before actually taking the vaccine?
I mean, so right now we don't have enough vaccine, or we won't have enough vaccine once the Pfizer and Moderna vaccines are approved to give it to everybody. Okay, so phase 1 will be healthcare workers that are taking care of COVID patients. So these are people that are taking care of patients, so nurses, respiratory techs, doctors, those that are actually taking care of patients, they're at the highest risk. And so that's phase 1. Phase 2 would be the high risk patient population. Those that have comorbidities, advanced age, that have a high risk of having severe, complications from it. And then phase 3 is going to be the general public. Okay, so phase 3 is probably not going to happen until probably spring of 2021. And so I think we have to just look at the safety data. So before these are approved, we'll get more information from Pfizer and Moderna about the specifics on the effectiveness of this drug in different populations. We want to take a look at that safety data. And then I would say, talk to your primary care physician about whether or not the vaccine is right for you. As it looks right now, it looks to be a safe and effective vaccine. So this is going to be a vaccine that will be right for the vast majority of people. And we definitely want to promote its use to be able to mitigate the effects of this pandemic on our communities.
A couple of people have asked about Intermountain specific qualifications for it. And if you do work for us, I know you can probably reach out to your manager to figure out how all of that is specifically working. So we'll leave that to the managers to figure out with people. I don't know if you have any thoughts about how it works for our specific caregivers, but you meant high risk caregivers or dealing with high risk patients would be first, correct?
That's correct. And they'll receive an email from their managers about whether or not they are, can get the vaccine. So the no-brainers are people that work in the hospital that see COVID-19 patients. Those are the people that absolutely are going to be first line, whether it be the ICU or the medical floors. But I would say talk to your manager and kind of understand if the manager knows at this point, and then we will be sending out emails in terms of who qualifies for the vaccine, in addition to how you go about getting the vaccine and scheduling an appointment with employee health.
And it's not mandatory. I just wanted to throw that out there. This is not a mandatory vaccine. I know that, not right now at least. I know that Intermountain and other care systems, we have mandatory flu vaccines unless you have an exception. But right now that is not something that we are doing. So I want to switch gears a little bit and talk about specific symptoms and just some cases that have come up. We've gotten some questions from people about the contagious period of COVID-19. A specific example was that someone had COVID around 3 weeks ago and they're starting to feel better, but they have some sort of lingering cough. Are they still contagious? And should they be coming to Thanksgiving?
So one, you shouldn't have people coming to Thanksgiving, period. I'm just going to reiterate that. So we think about the contagious period for people that are either asymptomatically infected or those that are symptomatically infected. So if somebody has symptoms of COVID-19, gets tested and is positive and has mild disease, meaning they don't have to be admitted to the hospital. Okay, so if they have mild disease, they're home and they have COVID-19, you are considered infectious for 10 days from the start of symptom onset, as long as you're afebrile by day 9 and your symptoms are improving, not gone, but are improving. So for people with mild disease, not hospitalized, it's 10 days from the start of symptom onset is your infectious period. And so that's why our self-isolation period is 10 days in people that are positive for COVID-19. So if somebody was infected 3 weeks ago and symptoms are improved, don't have to be gone, but are improved and they're afebrile, at 3 weeks, they are not infectious to anybody. In people that are admitted to the hospital that have severe disease, that 10 days goes to 20 days. And so it's a longer period of infectivity for people with severe disease.
I want to talk a little bit about therapeutics really quick. I know that there's been some updates about therapeutics that are being offered. Can you just give the community an update on what's been going on with that?
Right. So you may have seen in the news that the FDA granted an emergency use authorization on a monoclonal antibody that's being produced by Eli Lilly. It goes by the name bamlanivimab, something like that. I don't know. It's hard to say. And so that is an antibody that is manufactured and targets the spike protein on SARS-CoV-2. So this is the whole kind of idea about giving convalescent plasma. We talked about that months ago. But this is an antibody you give somebody when they have symptomatic COVID. They haven't generated an immune response, and we hope that giving this antibody would prevent severe disease. Okay. Now, the challenge is that this is a drug that's in very short supply, not just in Utah, but across the nation. It's a hard drug to make, and it's currently just in very, very limited supply. And so this drug will target patients that are outpatients that aren't sick enough to be hospitalized. You can give this drug hoping to prevent hospitalizations or further ED visits. That's the intent of this drug. Most likely is going to work better early in the disease course, meaning that you've only had symptoms for 3 or 4 days versus somebody who's had symptoms for 10 to 14 days. We are working with the state crisis standards of care to determine what are the state criteria to give this drug. And so that will be coming from the state in terms of what those criteria are. We only have enough for 2% of the population that gets COVID-19. So this is incredibly limited supply. And so we want to make sure that we're only giving it to people that are at the highest risk for decompensation or severe disease. And so if you come in, you have comorbidities, you're older, and you're sick with COVID, but not sick enough to come into the hospital, that's a person we may want to give this drug. But it's very challenging from an operational standpoint. Somebody comes into the ED, gets evaluated, they get swabbed, they get sent home. Now they're home and they have a positive test 24 to 48 hours later. They have to be identified, contacted, brought back into a healthcare facility to receive this infusion. and then sent back home. So it's a very complex drug to give. We hope that we'll be up and running across the state of Utah to be able to offer this drug for the most at risk by the end of next week. But we're currently waiting for the approval from the Crisis Standards of Care and getting the drug shipped to the state of Utah.
That's interesting. I could see some people being worried about having to come back into the facility again, which is kind of something you just mentioned, and how that would work. So that'll be an interesting thing to see what happens as we move forward. Eddie, is there anything else you wanted to mention to us before we take off for the day?
Yeah, I mean, just realize that 93% of our ICUs are full. We don't have much wiggle room there. We've gone through multiple initiations of our surge plan, meaning that we're opening up ICU rooms that have been regular medical surgical floors. We've moving patients all across the system to really optimize our ICU beds. We're transferring people to primary children so we can put adult patients in those pediatric beds. We have other plans to increase our capacity in terms of ICU beds, but know that ICU beds aren't the ones that care for these people. It's the nurses and the doctors and the respiratory therapists that care for these people. And they're getting really stretched thin, and care is changing in terms of how we care for patients, meaning that we don't have enough ICU nurses to take care of them. So we're bringing in new nurses that haven't worked with Intermountain before, moving nurses from different parts of the hospital into the ICU. We're still caring for patients, and we still want to make sure that if you're sick and you need care, you come to the hospital and be evaluated. But we're continuing to be at a very critical position. And with cases this high, 4,500, the most cases we've had, 18 deaths in a day, the most deaths we've had, this next week is going to be very, very important. And we need to make sure that we're all doing the best we can within the community to reduce the spread of this infection, because we anticipate that our numbers in the hospital will continue to go up next week and the week after, just based on the current infections we have right now. And the last thing we need to do is add to that with increased transmission at Thanksgiving. So I hope people can find a way to give thanks and connect with people, and connect with people digitally or in a very safe, effective manner, outside at a distance. And so we can give thanks and, recognize the fact that we are hopefully headed out of this with vaccines and all the other advanced therapeutics, but, recognize that there's going to be over 700 people that are not going to be at Thanksgiving this year because of this virus, over 250,000 people, individuals that have died this year that are not going to be at Thanksgiving, and do everything we possibly can to prevent that number from growing. And that is going to mean sacrifice right now. But keep in mind, the parties we're going to have this summer are going to be incredible. We're going to have Thanksgiving and Christmas in June and July, and we're going to celebrate with abandon. And let's do it then and not now. So I guess that'd be my parting thought, Amanda.
And just so everyone knows too, there's a bunch of platforms that are extending their time limit that they typically have on virtual meetings to be free for Thanksgiving. So if you look into those, you can find out who they are. But if you want to video chat into your family, you definitely have that option too. So thank you for the advice. I really appreciate it. And just a couple of resources for people watching. We have our COVID-19 symptom checker still available. You can go to intermountain.com/COVID testing. There's a quick questionnaire that you'll go through to determine if you qualify for a test. If you do, you'll be able to then select an appointment arrival time. Do know that appointment arrival times are put out a little bit right now just due to the demand in testing. Please be patient with our caregivers as we try to work through that. We also still have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. It's a great resource through this holiday season if you're needing some extra support from people. We're also hiring right now. We're looking for additional caregivers to come work for us. You can find positions at intermountain.jobs, and it'll show you a list of availabilities that we have there. Dr. Stenehjem, thank you again so much. And just so everyone knows, We'll be skipping next week to enjoy the holidays with our households, and we'll talk to you after the holidays.
Thanks, man.
Thanks.